Much. Moving on to Varsha, who will take us through the amniotic membrane transplants.
Varsha from Shankar Netralaya, Chennai, and I'm here to present my best 7 learnings with amniotic membrane transplantation. So now first, to use an amniotic membrane, it needs to be peeled off from the nitrocellulose paper that it is normally mounted on, and sometimes this is which is most difficult thing. So what I feel useful is to first identify a free edge with gently nudging along with the tying forceps. And once this free edge is identified, grasp the nitrocellulose paper with the second instrument and just pull it off in the counter direction. AMT just comes out easily. This prevents any buttonholes or entanglements of the AMT on the paper, just like that. Next, we need to identify the stromal and the epithelial sites of the AMT. Now, this is done using a Vexel sponge. The stromal side is the sticky side, and we would normally want it stromal side down. That was the reverse side, so we reversed the amniotic with the help of 2 forceps, and now we are rechecking again to confirm the sites. Always keep a counter pressure with the second instrument on AMT. Sometimes the AMT might just get stuck to the sponge while checking and just it comes off the surface. Now, AMT techniques basically can be divided into onlay techniques and inlay techniques, wherein the onlay is basically a biological bandage wherein the epithelium grows under the AMT does not get integrated. Vis-a-vis in the inlay technique, wherein we want the AMT to get integrated, so AMT provides a scaffold or a basement membrane for the cells to grow above it. Let's look at an onlay technique. This was a case of an SJS with a corneal defect for which an onlay AMT is being done, where AMT stromal side down is secured using perilimbal sutures. You can use 10-0 nylon sutures. You can also use vicarial sutures in the children so that suture removal is not required later. The suture bites are episcleral and not conjunctival so that the AMT remains anchored to the bulbar surface. You can have some bleeding while passing these sutures because these are inflamed eyes. You can use a Vexel sponge at the site of the passage of the sutures. It soaks as well as causes pressure hemostasis. Trim off the excess AMT that is there. You can also place corneal sutures if the defect is small to prevent the bleeding that happens. No additional glue is required in this technique. Always place a BCL over the amniotic, otherwise the next day after the patch removal with the blinking movement, the AMT can fall off. I always prefer to remove the drape myself because sometimes the drape is tightly stuck to the skin and the BCL might just pop off while removing the drape. Moving on to the inlay technique, in cases of pterygium, wherein you have a large pterygium or you have a double-headed pterygium where after the dissection, a large defect is created for which we might need a larger conjunctival autograft to cover it, AMT is useful over here as an inlay technique to cover the corneal and the conjunctival defect. It provides a basement membrane to facilitate epithelialization. So it is tucked in and it is trimmed to the size of the defect. It can also help to cover the donor area, following which a small conjunctival autograft is placed above the AMT to prevent the recurrences. We also use inlay techniques of AMT in acute chemical injury. This was a case of grade 6 Duas alkali injury where a 360 tenonplasty and alloslet was planned. Here, the entire bulbar surface area is bare, and the AMT has to be draped from the superior to the inferior fornix, giving a scaffold over which the alloslet bits will be placed to facilitate epithelialization. In this, I found which is useful is a divide and secure technique, where we place the AMT first on the entire surface, then we fold it in half, secure it with a glue on the superior half, ironing it out from center to periphery, tucking it in the peripheral rim beneath the conjunctiva. The same is repeated in the inferior half now. You have to iron out the AMT very nicely to avoid any kind of folds in the center. I do it from the center to the periphery, and this is followed by placing alloslet bits and BCL and tarsorrhaphy. We also use the same technique for autoslet in the chronic phases, wherein after removing 360-degree pannus, we are removing the 360 pannus, we are clearing off the surrounding 3 mm sclera, basically to allow faster corneal reepithelialization and preventing the conjunctival growth over the cornea. Herein, the AMT will only stick, we have to be careful that the AMT is sticking only on the raw surface. So the AMT is draped on the cornea and the surrounding sclera, depending on the size of the defect that it has been created. You have to be careful that it either tucks in or it just opposes the raw bed. It is not overlying the epithelialized conjunctiva. This is followed by placing the autoslet, BCL, and a tarsography. Sometimes we have defects which are small and there is thinning, wherein the AMT can be used as a patch. This is a case of a limbal dermoid for which following excision, the corneal bed had minimal thinning that did not warrant any corneal patch. So here, AMT was placed in the form of a patch. The AMT will not stick to the epithelialized area. So after sticking it on the raw bed, it is trimmed just to fit the defect. The residual conjunctiva is then placed back, followed by a BCL placement. And it's integrated well. So another case wherein we did a symblepharon release, following which we realized that there was a defect in the cornea associated with thinning. So here we decided to put a double layer of an AMT. This is the first layer. It is always better to have a AMT if you're filling in a defect to be a little smaller rather than big. Use minimal glue. Wash off any excess glue if it is there. Iron out, trim to fit the defect. After removing, I always like to check the edges if the amniotic has stuck properly or not. And if it is glue, you can just put a little bit of glue, stick it, iron it. Same thing was repeated in the inferior side also. The margins of this AMT should never override the surrounding epithelialized surface, because we want the epithelium to grow over the AMT. We want this AMT to get integrated. And as we can see, it has integrated well and there is no defect on the cornea or the bulbar conjunctiva. So my 7 best learnings I would say are: identify the stromal and the basement membrane sites. The stromal site sticks the sponge. A Vexel sponge is really useful to do that. Vexel sponge is my most friendly instrument. It helps in identifying the orientation. It is ideal for drying the surgical field. If you are using a cotton swab, sometimes the fibers of those cotton swab only get stuck to the AMT. It is also helpful in handling the AMT with ease. Fibrin glue is not needed for an onlay patch. Just a perilimbal or the corneal sutures are enough to ensure the stability. AMT will stick only to the bare surface, so delineate the raw area nicely. You can use a fluorescent strip also to do the same. Double check the edges. I always confirm that the edges of the AMT are securely adhered. Remove any excess glue, trim off any extra amniotic membrane. It prevents peeling of the membrane. And BCL is a must. Tarsography is the cherry on the cake. It secures the AMT, prevents unintended dislodgement in the immediate postoperative period, and most importantly, allows me to sleep well at night, knowing that my graft is stable. All the full videos of the same that I have showed you, you can have a look at our channel, Ocular Surface Gurukul. And this is our team. Thank you so much.
Thank you so much, Varsha. I think it was a very comprehensive talk on amniotic. Any comments from Arif sir or Dr. Paris?
Just a few tips, already beautiful videos and very nice depiction. When you get your amniotic membrane from the eye bank, sometimes while preparing, if they have not removed the chorion, you can get an amniotic membrane which is very thick. So if you find the thick membrane, then you identify the sticky site and then just spread the amniotic membrane, and if you gently wipe it with a cotton bud or a Merosal sponge, that excess chorion can be removed, because we just need the amniotic, we don't need that thick chorion. Second, yes, you rightly identified as onlay and inlay, but remember, whenever you put as inlay, the amniotic membrane will be present for a pretty long period of time, and it will take a very long time to go away. And especially if you put it in the visual axis, you'll have an issue where the the surface will look great, but the amniotic membrane will take a very long time to go away. In terms of using the glue, I like putting the two components separately. So if I have it, I fold the amniotic, I put the thinner component and the thicker component, either whichever way. That way it buys you more time when you take the amniotic membrane and you try to spread it out. If you put both the component and if there is some delay, sometimes you may have the amniotic membrane get crumpled and you can't really spread it out. Also remember that when you're using the glue, all the excess glue sometimes accumulates beyond the edges, and there it may remain like a clump. And the temptation is that you go with the forceps and you just try to pull the glue. Don't do that. If you did that, the extension of the glue on the undersurface of the amniotic will start, your amniotic, which is well attached, will become loose. So take a vannas, just catch the excess glue and trim it at the edge and remove it. And then, because same thing, when you try to separate the lids, you find that it's even sticking to the lid margin. In terms of putting the suture to secure it as onlay, purse string suture is what we don't put multiple sutures all around, because that's going to cheese wire and the amniotic will become loose. So always take larger bites and take a purse string suture kind of thing. And also at the end of when you tie the knot, don't make the edges very short, because on slit lamp later on, if you have to remove, the overlying surface heals and the edges get buried and you can't really figure out where to cut and remove it. I leave the knots inferior and I always leave it a little longer. So then what happens is, with the needle you can cut any of the purse string one edge, and the longer ends you can catch, and removal of that purse string suture becomes very easy. Just few points.
Thank you so much, sir.
Anything you would like to add, Dr. Paras? Yes, sir. Please go ahead.
When you get failed the amniotic membrane, how and when you repeat this procedure?
So we usually see at the end of 2 to 3 weeks, we expect the surface to have epithelialized. Usually the AMT, the life that we use, it gets disintegrated. So 2 to 3 weeks ke baad, we usually remove the BCL. We see if there is any kind of defect or not. If your defect is healing, if it is large enough, we might have to go again and repeat a second AMT. If it is healing, if it's small, then we can just continue with the steroid drops, place a bandage contact lens, keep a close watch for it to heal or not. If it's non-healing, then yes, again after a week or 10 days, we might have to take up the patient again.
Thank you.
The normal contact lenses have a diameter of 14 millimeter.
We put a large.
Place that, then what happens is, often this contact lens will fall off, especially if the underlying surface is thick or there is amniotic membrane. So go in for 16 millimeter diameter lenses.
Yeah, we always, yeah.
Because they stay on better. And what I do is, if I'm in a dilemma where the patient's contact lens is going to fall, because once the contact lens falls off, the amniotic membrane with the lid movement, it will become loose even if you have the sutures. So if you're going to put a contact lens and you feel that there may be a problem with the contact lens retention, put a paramedian tarsorrhaphy suture, which can be released in a week's time. You don't have to, this is like a temporary tarsorrhaphy, but by putting the paramedian suture, you can ensure that the contact lens will not pop out of the eye, especially if the patient is wiping the eye.
So that's a very valid point. In fact, which is why if you've seen all the videos that we showed, all patients, we always use a large diameter lens and we always do a tarsorrhaphy, because releasing the tarsorrhaphy in the OPD will take you hardly few seconds, but not putting a tarsorrhaphy intra-op and then patient coming to you with a fallen bandage contact lens, a lot of times the next day when the fellow is removing the bandage, the patch from the eye, the bandage contact lens just comes off. The children, they'll just go rub their eyes and the contact lens will fall off. So invariably, all patients, it's always better to do off a tarsorrhaphy. A temporary tarsorrhaphy never hurts.
You may have the patient come with the amniotic membrane saying,
Exactly. Exactly. So a lot of,
Yeah.
outside to the lid margin, when your patient comes to you, there is white, then
So-
you know that this is.
In fact, a lot of colleagues we have seen do not place a bandage contact lens over an amniotic if they are doing it because they feel that the amniotic is acting like a biological bandage contact lens. But the problem is with a blink, it's going to just shear away. So it's always better to place a bandage contact lens over the amniotic so that, you know, with your blink, nothing happens to the amniotic as well.
The large diameter bandage contact lens, you can, in India, you can get it from a company called Purecon or Silverline. So you can Google that and you will find, or maybe in trade, if you find that, you can take down the details, and if you want, you can order, because these are not readily available. The standard lenses, what you get from Varsha and all these things,
14
those
millimeters.
are all 14 millimeter. These are larger diameter lenses that are custom made and they have to be on.
Great. You want to add
No, no,
something?
just so very true that tarsography is a very, very underutilized tool. So one should not shy away from doing even a temporary tarsography for such patients. It's very important to have it in place.
Sometimes people don't do it because patients will complain. They feel cosmetically my eye is closed. But I think I tell the patient that if you want to have surgery, if you want to have success, this is mandatory.
Absolutely.
I even do it for my K-Pro cases sometimes. When I do a K-Pro and I put a contact lens on the eye, I will often do a tarsography. In the initial period, by the time things are settling down, we don't want that because it's so vital to have a contact lens. They lose that.